In the last 3 years, I have watched three of my friends walk away from surgery. Independent of one another, they cited a disillusionment so deep it amounted to moral injury. But why? Was it the call? Was it the infighting? Or was it something effectively invisible, something deliberately designed to be almost impossible to point your finger at? Every day, we show up. We train for a decade, we save lives, and we expect our compensation to reflect that immense value. But what if I told you the system designed to pay us isn't a compensation model, but a diversion mechanism? This diagram is the answer. It functions as a roadmap, not of payment, but of how value is systematically siphoned away from our hands and into the pockets of stakeholders. We are going to meticulously break down this machine, the CPT codes, the R.U.C, the RVUs, and the zero-sum game of budget neutrality. We will uncover a system built on manipulation by the very organizations ostensibly designed to protect us. Now, this isn't just an academic exercise, it's a matter of self-preservation, because if we know the tricks, we are infinitely harder to manipulate. I want to make a quick distinction. It's gotten me pretty confused in the past, but ICD codes are for diagnoses or problems. CPT codes, on the other hand, are for services, what we do. We are exclusively discussing services and the payment for those services. Let's set the stage and understand how we arrived here. Prior to 1992, our payment was largely governed by fee-for-service and usual, customary, and reasonable. It was market-based. We would determine our charges. For instance, for an appendectomy, you'd throw a dart at the board for the price. That charge would go to a local Medicare committee who would then compare the amount of money you're charging and compare that to the average in your area. If it was less than 90th percentile, it was paid. But there were some flaws. Big insurance companies and big government were quick to exploit these as unsustainable and inequitable. Basically, the charges kept going higher and higher and would never decrease. Furthermore, the system wasn't a fan of technical services being rewarded over cognitive services. And healthcare costs had skyrocketed and were consuming an alarming portion of the GDP during the 1980s. The fix arrived in the late 80s as 1980s healthcare reform. This fix came in the form of an alternative payment system. This culminated in the 1989 Omnibus Reconciliation Act, which mandated the resource-based relative value scale by 1992. To really understand the implications of this fix, we need to understand the historical currents that came together to allow such a radical restructuring of doctor compensation. We need to understand the positions of those in power and the priorities that they set for their future and, ultimately, for ours. The history of healthcare and its financing in the United States is a narrative of shifting power, external pressures, and a consistent erosion of physician agency. Before the 19th century, medical practice was rudimentary. Knowledge levels weren't much superior to ancient Greece and Hippocrates. Care was largely provided at homes and streets, and the few existing hospitals were places you went to die. There was no health insurance, and people were responsible for their own costs. By the mid-1800s, this brought the first accident insurance policies with the steamboats and railroad industries. The 1860s heralded the era of scientific medicine with breakthroughs like germ theory and anesthesia. This marked a profound shift, transforming medicine from an art of comfort to a science of intervention. Transformation of medicine into a science paradoxically, though, made it ripe for commodification. In 1892, a book called The Physician as a Businessman by J.J. Taylor offered some candid advice. It suggested charging, quote, according to the value to the individual, asking doctors, for what sum would their family bring lawsuit for the injury which you've repaired or the life you've saved, were his injury or death caused by the fault of some corporation? This wasn't about profiteering. It was about recognizing the immense value of medical intervention. Fees reflected risk adjustment with higher charges for late-night consults, procedures with more intensity, or journeys across terrain. This was a starkly different landscape where the intrinsic value of a physician's service and the risk assumed was directly acknowledged and compensated, a concept largely obliterated by today's system. The very phrase risk adjustment in that context meant something completely different than the bureaucratic box ticking we see today. At the early turn of the 20th century, we witnessed health insurance slowly gaining traction. By the 1920s, on the cusp of the Great Depression, the idea of prepaid healthcare began to normalize. The seminal Baylor Plan of 1929, offering teachers 21 days of hospital care for 50 cents a month, became an influential model for plans like Blue Cross. But insurers were initially wary due to the adverse selection, that is, the inherent financial risk that only sick people, those most likely to use services, would purchase their insurance. Insurers then, as now, prefer healthy people who pay premiums but rarely use services. World War II dramatically changed the world and it reshaped the American healthcare landscape. Rampant inflation in the 1942 Stabilization Act, which froze wages, forced employers to get creative. Unable to offer higher salaries, these employers began offering health insurance as a, quote, benefit to attract and retain workers. Now, this was a pivotal moment, cementing employer-sponsored health insurance as the dominant model. The influx of younger, healthier people into the insurance pool dramatically reduced adverse selection, which made the insurers quite happy and profitable. Arguably, the most insidious development of this era was the 1945 McCarran-Ferguson Act, which was born from a solvency crisis amongst insurers. This granted a sweeping exemption from federal antitrust laws to insurance companies. It allowed insurers to collude, share sensitive data, and fix prices without fear of prosecution under the Sherman Antitrust Act. The McCarran-Ferguson Act proved wildly successful for insurers. Health insurance coverage exploded, rocketing from less than 10% of Americans in 1940 to over 70% by 1955. At the time, this was mainly major events like hospitalizations. The fee-for-service and the UCR models remained in place, but insurance became increasingly involved. Still, though, the doctor-patient relationship remained intact. Doctors set their usual, customary, and reasonable fees. The patients would typically pay the doctor directly, and then the patient was reimbursed by their insurance. This preserved a degree of physician autonomy and a direct financial relationship with the patient, fostering accountability and a clear understanding of value. The baby boom of the 1950s saw 76 million Americans born. While the immediate financial impact wasn't felt in the 1950s, this demographic wave was basically a ticking time bomb. It represented an enormous future demand for healthcare, guaranteeing a massive sustained explosion in costs as this generation aged. The watershed moment was in 1965 with the Social Security Amendments, otherwise known as the Medicare and Medicaid Act, which was signed by President Johnson. Historically, the AMA was staunchly opposed, yet finally relented because the plans at that time were structured favorably for the doctors, especially Medicare Part B. The average life expectancy was 66 at that time, and the government and insurers underestimated the costs, predicting less than $500 million annually. They were catastrophically wrong. By the early 1970s, Medicare and Medicaid costs ballooned to over $13 billion per year. This massive influx of insured patients into the system led to doctors across all specialties doubling their incomes by 1970. The percentage of GDP which was dedicated to healthcare skyrocketed, creating a frenzied clamor for national healthcare in the early 1970s. Now, quite keenly, the AMA, in a move of strategic co-option, created the current procedural terminology or CPT codes in 1966. This provided a standardized language for services, but also ensuring a seat at the table. This expansion of government-backed insurance was a godsend for physicians in the short term, but it also initiated an unsustainable upward spiral of costs that would demand drastic and ultimately punitive reforms in the decades to come. The 1970s and 1980s were a period of escalating crisis. Healthcare costs continued their relentless upward trajectory, consuming an ever larger slice of the GDP, from 8.9% to an alarming 12.1%. This was fueled by a parabolic growth in advanced medical technology and knowledge. For instance, the CT scan in 1972 and the MRI in 1977. These revolutionized diagnostics but came with astronomical price tags. By 1985, average life expectancy increased to 75 years and the Medicare budget ballooned yet again to over $106 billion. Both the aging population living longer and the widespread availability of expensive life-prolonging technologies brought back this adverse selection, now with a vengeance. It was exacerbated by moral hazard, that is, the increased likelihood of being risky or having risky behavior because you just have insurance. This combination made an unsustainable situation, and it was this desperate need to control costs, coupled with immense lobbying pressure from stakeholders, that pushed us into radical healthcare reform in the 1980s. By the mid to late 1980s, the alarm bells were deafening. Both insurers and the Reagan administration desperately sought a solution to control runaway healthcare costs and, critically, to rationalize how the doctors were paid. The answer came in the form of William Hassall and his Harvard team of economists and statisticians between 1985 to 1988. Now, Hassall, an actuary and not a doctor, was tasked with making an objective method to value physician services. giving birth to what we now call the Resource-Based Relative Value Scale, or the RBRVS. The goal? Well, the goal was to quantify the, quote, real cost of providing care. But hey, it was the 1980s, right? So with primitive data accessibility, this was a pipe dream. What they ultimately created was a method to quantify the relative cost. No longer would physician fees be market-driven. Instead, an academic committee would impose a top-down, resource-based valuation. This was when physicians began to lose a significant amount of autonomy, as their autonomy was now dictated by an external, supposedly objective system. Culmination of these efforts was the 1989 Omnibus Budget Reconciliation Act, otherwise known as OBRA, which mandated a complete overhaul of physician payment. OBRA codified a new fee schedule, introducing the concept of budget neutrality, which sounds innocuous but has become a suffocating constraint on compensation. More on that later. Out went the market-based physician fees, declared inefficient and unsustainable, and in came the RBRVS with its RVUs in 1992. OBRA did not just transform healthcare finance. It began the unrelenting erosion of physician autonomy governed by financial expediency rather than professional value. We've covered the last couple centuries of American healthcare history, landing us right at 1991 to 1992. The stage is now set for the RBRVS and its mechanisms that would fundamentally reshape physician payment. Our remaining focus will be on the factors or the foundational flaws that were established in this crucial period and their effects. The Resource-Based Relative Value Scale, otherwise known as the RBRVS, aimed to tie reimbursement to the inputs or the resources, such as work and cost, required for a service by being the governing factor in the center of the payment process. It is the underlying framework that dictates how your money, once it's coded, is valuated and ultimately reimbursed. The RBRVS applies specifically to the journey from your service to money. The original stated objectives of the RBRVS were deceptively straightforward. First was to create a relative value scale based on resource costs. Second, to subject these scales results to review by doctor panels from specialty societies. And this was probably just to help lend credibility in physician input, but often serving as a rubber stamp or a venue for infighting. Third, to subject these values to review by stakeholders, CMS, big insurance, and big hospital administration, the very entities with vested interest in controlling physician payments, and maybe this wasn't the best idea. And fourth, to design a methodology and process for ongoing review of RVUs, which ultimately became the purview of the RVS Update Committee. The RBRVS goals, outlined in 1987 to 1988, were to standardize payments, rationalize incentives, and influence doctor decisions, and to also provide a neutral incentive structure and enhance cost effectiveness, while supposedly fixing manpower shortages like primary care. These platitudes may seem quite similar to the hollow promises we hear today from proponents of value-based care. The takeaway is this: these were economic theories applied to medicine, attempting to quantify an intrinsic value for services. But value, especially in medicine, is subjective. Take this painting by de Kooning. Someone paid $300 million for this. I couldn't, but hey, value is in the eye of the beholder. Water at the sink is free, but water in the desert if you're dying is priceless. And to bring it home, how much would I pay for an ET thoracotomy for a loved one? The RBRVS, by design, fundamentally ignores the value perceived by the patient, especially in emergent situations. It denies that any intrinsic, non-quantifiable value exists. The core RBRVS methodology, aiming to quantify relative costs of services, revolved around three primary factors that were initially proposed. Number one, time, the pre-service, intra-service, and post-service. Number two, the intensity of work per unit time, or otherwise known as IWPUT, which is more or less a highly subjective and nebulous concept wanting to reflect the mental effort, technical skill, and stress involved. And finally, costs, which is the money, including overhead, and briefly, our opportunity costs, meaning the foregone earnings during our lengthy training. So let's dissect this sacred formula of total work. Now, this is a deceptively simple equation, but it's pre-service time multiplied by intensity. You add this to your intra-service time multiplied by intensity, and then you add this to the post-service time and multiply it by intensity. At its heart, the work is defined as time multiplied by intensity. But what is intensity? It's a subjective blend of mental effort, technical skill, and stress, a vague, unquantifiable metric. This concept of IWPUT became central. And as a personal sidebar, I've always tried putting my finger on that one thing that separates surgeons from medical doctors. On call 24/7, centimeters away from dissecting into morbidity and mortality, being sued over cosmesis, never truly being mentally off, probably IWPUT. The foundational model for defining the dimensions of physician work, the very bedrock of how our work is valued, was made by a single psychologist who interviewed just about 20 experienced doctors of various specialties in the greater area of Boston in the 80s. 20 doctors in one metro area providing subjective opinions formed the basis for a model that would dictate how all United States physicians are paid. There is no objective validation for this model, yet it persists. This process, fundamentally a subjective task without objective solution, basically creates the appearance of removing judgment while in fact embedding it into the very construction of the formula and the measurement of its inputs. Magnitude estimation is a global assessment of our work. This is the core, unvarnished truth of the RBRVS valuation process, but it became more or less a breeding ground for highly exaggerated, unaccountable estimates because there were no objective standards to assess them against. It was, and still is, a subjective free-for-all. Let's revisit some of the RBRVS surveys. Official surveys asked doctors to pick a reference procedure, maybe carpal tunnel for orthopedics. They would assign it on 100 points and then rank all these other procedures in their specialty relative to that baseline, then estimating pre-service, intra-service, and post-service time, then comparing it to intensity. Now, with these numbers, I'm obviously being hyperbolic, but I'm making the point that this was and still is the methodology used to assess your services, and it was highly subjective. The problems were also manifest. Over 7,000 CPT codes, yet only 800 surveyed. No direct pre- or post-op time estimates, and inconsistent scales across all specialties. Now, to start digging, this is where general surgery did not show up. And as we'll prove shortly, general surgery never really showed up. Now, there was a day a while back where I was with my medical student. That day, we had some scopes, clinic, and so forth, but we also had these 3 cases. And interestingly, the RVUs all washed out to similar values. Let that sink in. A robotic incarcerated femoral hernia repair, high complexity, high risk, is essentially valued the same as a straightforward portacath, or even less so than a breast biopsy. This isn't a relative value scale, it's a grotesque distortion. This is a direct consequence of general surgery's historical misrepresentation and the deliberate manipulation of the system by other specialties. When your specialty's work is underestimated or actively suppressed, you end up getting paid like a Kia for delivering a Ferrari-level service. So the RBRVS is the framework that allows services to be evaluated and assigned RVUs, but who is doing the valuation and how are these even determined? The current procedural terminology, or CPT, is the universal language of medical billing. It's the initial step that's translating your complex services into money. Going back to our central diagram, the service that you provide is distilled into these 5-digit codes, or the CPT codes. These codes are the fundamental units that trigger the entire valuation and reimbursement process. CPT codes are the gateway by which our services must pass. Control over their creation and valuation is paramount. Trademarked by the AMA in 1966, CPTs are the standard for reporting medical services to insurers. Now, the AMA does not publish a figure specifically labeled CPT codes, but they do report revenue under the category of royalties and credentialing products. Based on their public financial reports, the revenue from this category has been, at least in 2023, $308 million from royalties and credentialing products. Now, mind you, this is just for CPT codes. Moving along, all codes, whether new or old, can be subjected to reevaluation, evaluation, or deletion. This makes control over the CPT process an immense source of power. This power rests primarily with 2 entities, the CPT Editorial Panel and the CPT Advisory Committees. Over 11,000 CPT codes exist, but a very small fraction, less than 1%, account for the vast majority of Medicare spending. 20 codes alone capture 50% of all doctor payments. The critical point? To significantly impact Medicare spending, you must target high-volume E&M codes used by every specialty rather than much less commonly used codes. Yet, even within this list of 20 of the most critical high-volume codes, those for critical care, ophthalmology, and surgical pathology have not been updated in 15 to 20 years. In this system filled with thousands of codes with many rarely used, you can start to see the inefficiency and problems. And maybe a topic for another time, how this could be rigged. The CPT editorial panel is the gatekeeper of CPT codes. Any code, whether new or existing, can be reevaluated, modified, or deleted. The process begins with a request, which must demonstrate a level of interest and provide level 1 data. Basically, it's evidence to support a proposed change. Now, as the gatekeeper, the panel decides what gets coded and how it's framed. The decisions made here have large upstream and downstream effects on physician reimbursement. The takeaway? The CPT editorial panel determines which aspects of your practice are visible and valuable to the payment system. Taking a look at the CPT editorial panel of 2025, you may quickly appreciate that there is something lacking: general surgery. One other thing you'll start to pick up on is that if your specialty has strong representation with this entire system, you have more lobbying power than those that don't. If you take this to the next step, you can start to understand why there are extreme salary and RVU discrepancies between certain specialties, despite those unrepresented specialties working harder than those that are represented. Then you can realize why certain specialties are allowed to have 2 ORs, multiple mid-levels, and be strictly outpatient and not inpatient. But hold on to your seats because we're just getting started. Here we have the initial stages of the coding process. Your service and work must first be conceptualized and submitted to the CPT editorial panel, which functions as the gatekeeper. Without their approval, your service, no matter how vital to patient care, cannot and will not enter the system of valuation and reimbursement. The CPT advisory panels, or essentially Specialty Society Advisor Panels, are the next layer. These panels are comprised of about 300 advisors or experts nominated by their specialty societies. These panels advise both the CPT editorial panel and the R.U.C on matters of coding and revisions relevant to their specific specialties. Their process involves internal discussions, multi-team planning, and then a specialty society advisor lobbies directly to the R.U.C on behalf of their specialty. Now, this sounds like robust physician input, right? But in practice, it's where interspecialty political battles start to be fought. Each specialty society lobbies aggressively for its own interests, often at the expense of others. These advisor groups, often leading figures within their subspecialties, are expected to represent their constituents, but they operate within a system that encourages a zero-sum mentality. So the image of Nuremberg here is not accidental. It symbolizes the morally dubious process by which physician experts testify to the value of their work, often to the detriment of others, under a system that pits specialties against each other. The specialty advisors are the critical link between the CPT panels and the R.U.C. They are nominated by their specialty societies, then approved by the AMA House of Delegates. The specialty societies send out surveys, compile the data and talking points, and then send the advisor to the R.U.C with this data and talking points. Let's recap. So far, we can see that the journey for our services valuation is already a bunch of interconnected steps. It starts with the CPT request, flowing into the CPT editorial panel, which sets the coding, who are then advised by the Specialty Society CPT advisor panels, and the society panels make and compile surveys and then summarize these surveys with recommendations. And often these are self-serving, biased, and compiled by their own experts. And then finally, the recommendations are championed by the R.U.C advisor who functions as a lobbying arm to the R.U.C. This is a complex dance of committees, surveys, and lobbying. This dance allows the ability to create the illusion of objective valuation while hiding deeply entrenched self-interests. Consequently, this allows specialty societies to advocate for themselves, but it fundamentally relies on effective and true representation, which has been absent for general surgery. If you dig a little deeper, you can start to exhume the devastating reality for general surgery. The General Surgery Coding and Reimbursement Committee, or GSCRC, is a deceptively named voice for general surgery within the CPT advisory panels. Its assumed process is supposed to ultimately have the GSCRC advisor lobbying the R.U.C on behalf of general surgery. Here's the explicit truth. There is no genuine general surgery representation on this committee, nor has there ever been historically. The ACS, which established this committee, does not represent the broad spectrum of general surgeons. The GSCRC roster is populated only by a multitude of subspecialties. These are lifelong academics, often with decades within the system. Their clinical focus, practice patterns, and financial incentives 100% diverge away from the frontline, rural, or community-based general surgeon performing a wide array of bread-and-butter operations. These subspecialists, while individually expert, collectively fail to represent or prioritize the well-being of the true general surgeon. They lobby for their specialized, often higher valuated procedures at the implicit or explicit expense of core general surgical work. This systemic lack of any unified voice for general surgery is a primary reason for the specialty's regressive reimbursement patterns and ongoing devaluation. It's a calculated failure of representation. The composition of the current ACS delegation to the AMA House of Delegates is, like the GSCRC, dominated only by subspecialists. And this trend doesn't stop here. It descends throughout the system, and it goes to the top. And once you're at the top, you realize just how unrepresented you, as a general surgeon, truly are, and how you do not have any dedicated voice for general surgery throughout the entire system. Not only that, but you realize how every other surgical specialty, with their own specialty societies and other surgical specialists completely outside of the general surgery training pathway, are deeply entrenched within the ACS to help lobby for their financial interests and improve lifestyles. The RBS Update Committee, or RUC, is the heart of the RVU valuation process. It was created out of the stark realization that an ongoing body was needed to manage the constant flow of new CPT codes. The RUC was positioned as the expert committee that would then help CMS navigate the system. So far, we've traced your service through the CPT coding process, right to the doorstep of the RUC. The RUC is the juncture where your clinical work, distilled into a 5-digit CPT code, is given a number that will ultimately translate into your compensation. The RUC, or RBS Update Committee, was created by the AMA in 1991, just months before RBRVS became law. The AMA controls the RUC and framed its role as exercising its, quote, First Amendment right to petition the federal government, which is a pretty clever rhetorical way to legitimize control over the valuation process. The RUC is a powerful, politically savvy entity that directly influences how billions of dollars are distributed across specialties. Its very existence is a testament to the AMA's successful co-option of the payment process, ensuring its continued relevance and influence long after the roller coaster of the mid-20th century. In theory, the RUC members, quote, exercise individual judgment and do not advocate for their own society. To push a de facto RVU ruling forward to CMS, a 2/3 vote is required. CMS has historically accepted 90% of the RUC's recommendations, and this acceptance rate reveals the RUC's immense power. It is effectively a parallel government of physician payment. The RUC is an expert panel composed of 32 members, about 22 of which are nominated by specialty societies, and their appointments must be approved by the current RUC. The RUC meets 3 times a year to deliberate and formulate its RVU update recommendations, which means the evaluation of physician work is a continuous and intensely political process. Each meeting is more or less an opportunity for specialties to push for increases in their codes, knowing full well that under budget neutrality, any gain for one specialty often means a loss for another. This constant cycle maintains a state of perpetual agitation and infighting among physician groups, distracting them from the stakeholders who benefit from this fractured system. The RUC operates largely behind closed doors. The data and proceedings are pretty difficult to access, shielded by a lot of red tape and a quasi-secret society aura. The reasoning for this opacity is to, quote, avoid lobbyists and industry influence. But really, it often serves to hide the self-serving maneuvers that occur behind closed doors, right? For the average physician, trying to understand how their codes are valued means wading through a quagmire of confusing and convoluted variables. This lack of transparency is a deliberate feature, not a bug, ensuring that the critical decisions regarding physician compensation are made in an environment insulated from broader scrutiny, further cementing those already in power. How the RUC evaluates is by taking a CPT code and, using the RBRVS framework, assigns a de facto RVU comprised of 3 components: work RVU, practice expense RVU, malpractice RVU. As already noted, the process considers specialty advisors, surveys, and other references, services, and so forth for comparison. Within a tightly integrated ecosystem, the RUC works closely with the AMA, CPT panels, all specialty societies, and CMS. The process unfolds like this. The CPT process goes through, and then data collection and specialty surveys are conducted by specialty societies, and supposedly these are sent to random samples. However, there's many reports that this is rife with selection bias. Thereafter, the specialty societies compile the survey results, and you only need 30 responses on these surveys to deem them valid. Survey questions are typically designed to solicit inflated estimates for work. For example, there's been reports of intra-service time and intensity of work per unit time often overestimated by 20 to 40%. Hence the reasoning why the RUC only really takes the 25th percentile on these recommendations. And then finally, after compiling these survey results, a specialty society advisor uses the results and lobbies to the RUC. And what these specialty society advisors use is the Summary of Recommendations, or the SORs. The Summary of Recommendations are meticulously crafted documents and used by RUC advisors as the primary ammunition to lobby. These are not merely reports. They are political manifestos designed to persuade and influence the RUC members. The quality and the strategic manipulation of these SORs can make it or break it for a specialty's RVU trajectory, further emphasizing that this process is a game of influence, not objective science. Medicare Part B's budget neutrality is possibly the most destructive aspect of the RUC's operating environment. This means that it's a zero-sum game. Any increase in RVUs or addition of CPT code for one service or specialty has to be offset by decreases elsewhere to maintain the budget. This brutal reality forces constant infighting amongst all specialties, turning the RUC into more or less a Game of Thrones, or robbing Peter to pay Paul. This creates perverse payment distortions. This system actively disincentivizes and debases essential but poorly lobbied specialties. For instance, dermatology famously claimed excessive time and follow-ups for freezing actinic keratoses, inflating their RVUs while other specialties got cut. The big point here is that CMS retains final authority on a CPT's RVU, but it is bound by this budget neutrality. So you do a service and a CPT request is created. The request goes through the CPT panels, specialty societies, and surveys, and then the lobbying efforts of their RUC advisors. The RUC ultimately receives all of this input and within the RBRVS framework provides a de facto ruling for the total RVU. Relative value units, or RVUs, are the currency of your hard work. They are not dollars, they are abstract units designed to reflect the relative value. The total RVU is the foundational metric that CMS converts into actual money. The total RVU is composed of three distinct parts: work RVU, which is the doctor's RVU, practice expense RVU, which is more or less the hospital's RVU, and then finally malpractice RVU, or malpractice insurance RVU. The WRVU, or the doctor's RVU, makes up about 48%. It tries to measure the physician's effort based on, yes, the RBRVS, and it consists of time, pre, intra, post-service time, the intensity of work per unit time, and then finally, the skill, the stress, the mental effort, everything that goes into the words skill and stress. The WRVUs in their current state largely benefit the employer, not the physician. Doctors, especially those on graduated WRVU productivity scales, are incentivized to see as many patients and bill for as many RVUs as possible, which keeps the hospitals busy and profitable and creates a volume-driven rather than a value or time-driven compensation model. This system quantifies output, not input, and punishes comprehensive multifactorial cognitive care that can't be neatly packaged into a single code. For instance, critical care coordination, complex phone calls, patient portal messages. But, something crucial is missing, and that is the crippling education debt and massive opportunity cost. The WRVU calculation completely disregards education debt and opportunity cost. The average unsubsidized education debt exceeds $300,000 to $400,000. By the age of 32, the opportunity cost, or the foregone income, has easily surpassed $500,000. This means a new surgical attending often begins their career with a financial burden of $800,000 to $900,000 or more. Now, this was not an oversight, it was a deliberate exclusion. The reason for this was to, again, try to reward cognitive services over technical services. The original Harvard team did recommend opportunity cost, but the PPRC, which was a division of HCFA, and HCFA has now become CMS, the PPRC promptly rejected it between 86 to 89. This decision made decades ago systematically devalued the immense personal and financial sacrifices physicians make, and it continues to cripple them to this day. This WRVU equation right here, work equals time multiplied by intensity, is the theoretical heart of your compensation. The Achilles heel lies in intensity, which is profoundly subjective. There are no objective relative weights associated with its traits. It's a global estimate that, when combined with time, is referred to as magnitude estimation. The inherent subjectivity leads to immense controversy and manipulation. And so, the intra-service time has become the dominant and often predictor of estimated work. RAND studies have even shown subspecialties like dermatology, orthopedics, and so forth overestimating the intensity of work per unit time by an average of 20 to 25%, with outliers reaching over 40%. This overestimation directly inflates WRVUs, leading to higher payments based on fabricated effort. So we went through some historical surveys, but what goes on now? Well, today, after the service request goes to the CPT editorial panel, specialty societies create surveys which get sent out to recipients. The survey consists of the following: a basic vignette. Number 2, a description. And now, here with the description, there's strategy in this, right? You want to play it up. You want to make these things longer, because more length in these vignettes and these descriptions means complexity. And complexity means you should be able to get a little bit more valuation. Number 3 is to answer questions. And like we compared to the historical surveys, what you do is pick a similar reference procedure. You give estimates for time, pre-service, intra-service, and post-service, and then you compare intensity. And then you estimate the work to 2 decimal points. And this right here is the most important question. From here, the answers are compiled, and they are compiled into a survey to include the WRVUs. And the WRVUs on the survey are the most important part. From here, your specialty society advisor to the RUC presents these summary recommendations, including for the WRVU, to the RUC. The RUC frequently recommends the 25th percentile, which is a subtle acknowledgement that respondents tend to overestimate their work. The practice expense RVU, or the PERVU, is the hospital's RVU. It's calculated by an opaque 19-step process dictated by CMS using an elaborate overhead calculator, and it takes into account overhead costs like personnel, resources, and location. The PERVU became fully resource-based in 2002, which was a move that massively benefited hospitals. This goes on to outline how lobbying arms aggressively and successfully argue for higher practice expense RVUs, often down to the most granular details like the number of graham crackers. The direct input into the PERVU calculation allows hospitals to capture a large portion of value generated by doctor services, diverting it away from them. This is a primary mechanism by which hospitals profit from employing physicians, and why facility fees have become so ubiquitous and resented. This economic structure is essential to understand why hospitals aggressively acquire doctor practices and why our income, when adjusted for inflation, continues to be stagnant or dwindle. When a physician is owned by the hospital absorbs all of the PERVUs, or the overhead, and they also absorb all of the mRVUs. This leads to income stagnation. Why? Well, the doctor can only get WRVUs, no PERVUs nor mRVUs, which limits their share of the total value of their labor. This PERVU spreadsheet demonstrates the sheer complexity, which is, again, a deliberate obfuscation and makes it nearly impossible for the average physician to scrutinize or challenge their numbers. Finally, the mRVU, known as the malpractice, or sometimes you'll see the PLRVU, or professional liability RVU, and this accounts for less than 3 to 4%. The mRVU is ostensibly based on estimated risk for a service and exhibits geographic variation to differing malpractice premiums across states. CMS collects data from insurance carriers to set these rates. While a minor component, mRVU is still subject to the same political and data-driven considerations as the other RVUs. So the total RVU formula for any CPT code: WRVU plus PERVU plus mRVU. But the total RVU is not yet money. Rather, it's just a number that will determine how much you're paid. CMS is a governmental body that holds immense power, acting as the ultimate arbiter of physician reimbursement for millions of Americans. After the RUC provides the de facto RVU valuation, CMS steps in to perform the de jure valuation through the Medicare Physician Fee Schedule. The Medicare Physician Fee Schedule, or MPFS, administered by CMS for Medicare Part B, is the official list of payment rates CMS uses to reimburse us. It is governed yet again by budget neutrality with a fixed annual budget of $93 billion, which has not changed since the initiation. The MPFS includes about 9,000 to 10,000 Level 1 CPT codes. The fee scheduling process involves collecting data on resource costs, consulting with physician groups, and then processing these inputs according to OBRA and the RBRVS. The critical point here is the conversion factor, or the CF, which serves as a benchmark for most commercial insurers. The key point again is that the effects of the RUC reach far beyond the MPFS. Now, the point I'm trying to make right here is not to demoralize. It's here to emphasize what is actively happening. The conversion factor is the single most critical component in converting your RVUs into actual dollars. The trend of the conversion factor is a catastrophic indictment of the system. Since 2020, the conversion factor has plummeted by 33%. From 1992 to 2025, it has increased only by 4.3%, starting in 1992 at $31 and to today, $32.35. In that same period, inflation has soared by over 129%, averaging 2.54% annually. More tellingly, from 2001 to 2025, while inflation collectively increased by over 70% and hospital payments kept pace with inflation, doctor payments increased by a meager 10%. Why this egregious disparity? The answer is brutally yet sadly simple. Physicians have no bargaining power nor leverage, unlike the other stakeholders. The annual conversion factor is set by Congress, not automatically indexed to inflation, nor the Medicare Economic Index that measures practice cost inflation. Congress consistently sets payment updates below MEI for budgetary reasons, leading to this significant decline. The stakeholders, the hospitals, the insurers, and pharma have formidable, well-funded lobbying arms that ensure that their interests are protected and that their payments keep pace with inflation. Physicians, fractured and poorly represented, are left to watch their real income divert away to the stakeholders. The outcome is inevitable. No representation and no lobbying leads to systematic devaluation. This table reveals the grim reality of the conversion factor's trajectory since the RBRVS in 1992. Note the separate conversion factors, surgical and primary care, up to about 1997. With the Balanced Budget Act in 1998, a single conversion factor was the rule, which was designed again to shift value towards cognitive services. From that point on, the conversion factor has been a roller coaster of marginal increases, flat years, and brutal cuts. Notice the consistent negative percentages in recent years. These are not minor adjustments. These are systemic devaluations that never address the fundamental flaw, that the conversion factor is not tied to inflation, and that doctors lack the collective power to demand fair indexing. Budget neutrality, mandated by OBRA in 1989, is the single most corrosive force acting on physician compensation. It ensures a zero-sum game. Any increase in physician spending, whether from new CPT codes or increased RVUs for existing services, must be offset. This means either number one, decreasing RVUs for existing services, or number two, decreasing the conversion factor for all specialties. CMS has a $20 million threshold. So if doctor spending increases by that amount, the conversion factor for everyone automatically drops to compensate. This ensures constant infighting and prevents any real growth in physician compensation. Even more, the system breeds low morale, fuels burnout, and fosters a pervasive sense of being undervalued. It deliberately creates a Game of Thrones scenario where specialties are forced to cannibalize each other. The GPCI, or the Geographic Practice Cost Index, is yet another variable applied by CMS to each RVU component, and it accounts for regional variation. It adjusts for cost of living and physician wages, or WRVUs, employee wages and facility rents, or PERVUs, and differing malpractice premiums, or mRVUs. GPCIs are a complex, often politically influenced mechanism that further complicates physician reimbursement, adding yet another layer of regional inequity to an already unfair system. So here's a quick conceptual bridge, reminding us of the intricate interconnections within CMS itself and how its decisions cascade throughout the broader healthcare ecosystem. Here is the ultimate formula of the Medicare Physician Fee Schedule. This is how your labor, dissected into its parts and numerically valued, is finally converted into a dollar amount. Each component of the total RVU is multiplied by its respective geographic practice cost index to adjust for regional differences, such as work GPCI. The sum of these are then multiplied by the conversion factor to yield the final Medicare payment for a specific service. This formula right here is the core mechanism by which CMS dictates your final worth, which is a testament to the power of bureaucratic quantification over the intrinsic value of medical expertise. Here, we re-emphasize the key players in the Medicare physician fee schedule: the R.U.C, which determines the total RVU and its parts, and CMS, which applies the GPCIs and, most critically, sets the conversion factor. This final formula reveals the profound control these two entities exert over your reimbursement. This final iteration of our flow diagram now reveals the full picture of how our money flows, or more accurately, how it's diverted. It all begins with your essential service, which is coded by CPT codes valued by the R.U.C, ratified by CMS, then further mediated by the stakeholders before a fraction reaches your pocket. To reiterate, the MPFS formula is the precise mechanism by which the payment amount for a service is determined. It is the cold, hard math that dictates your professional income, meticulously controlled by CMS and the R.U.C. It is the financial operating system of modern medicine that has been painstakingly designed and often strategically manipulated to serve the interest of the stakeholders rather than justly compensate you for your invaluable work. The cycle of money, diversion, and control extends far beyond just physician reimbursement. The initial stream of your service goes on to flow into a vast ocean of interconnected financial interests. This diagram is incomplete without identifying the true stakeholders who exert immense influence throughout the system. CMS, the ultimate regulator and payer; the big insurance companies with their powerful lobbying arms dictating rates; big pharma and PBMs controlling drug costs and formularies, also with their powerful lobbying arms; and last but not least, big admin, AHA, negotiating overhead, driving the regionalization of healthcare, and also with their own powerful lobbying arms. These stakeholders are not merely interconnected. Each is vying for a larger share of the healthcare dollar. Each entity actively maximizes its share of the healthcare dollar. The physician, providing the essential services that fuels this entire economy, becomes marginalized while the intermediaries and administrators swell in power and profit. General surgery is dying, if not dead already. Nearly 90% of surgical residents go on to do a fellowship. This leaves a paltry 10 to 15% who go on to practice true general surgery. Of that small fraction, only 15 to 20 surgical chiefs a year go rural. Some could argue, well, surgical oncology, colorectal guys, they can handle some gallbladder and hernia operations. Sure, but this misses the point entirely. Will the subspecialist answer the 5 p.m. call for every surgical void? Will they even go rural? Could they even go rural with their subspecialty? Will they do the amputations, the wound care, and the garbage reimbursing scraps that no one else wants to do, nor will do? The answer is a resounding no. This is my narrative. A mountain of cold, apathetic facts grinded and data mined over 5 years to find out the root cause of the problem. The system is permanently and fatally compromised and has been for nearly 40 years. My hope is that this information is used and your own opinions are formed, because the reason I am doing this is to spark conversations between doctors to start brainstorming on how to fix this. We read article after article after article of how bad things are and how bad things will be in year 2040, 2033. Yet nobody wants to break down this intentionally complex system to find the root cause. Instead, we keep talking about it and giving echo chamber solutions that have been spat out for decades. This failure to address the root cause is not an accident. It is by cold, unfeeling design. Nothing is working, nor has it worked. Since the initiation of the RBRVS, all we have borne witness to is bandage after bandage after bandage. The Balanced Budget Act, the Affordable Care Act, value-based care, APMs, AAPMs, MACRA, QPP, MIPS, going back and forth on the number of conversion factors. The list goes on. All the while, your compensation is increasingly siphoned away to stakeholders and the patients, which is every single one of us, are left out to die. When the problem keeps hemorrhaging despite these bandages, isn't it past time to realize what we have been doing hasn't been working? The 1990s are far gone. Our world has changed drastically, but the foundational payment system remains fossilized in that era. All of our time, effort, and intensity of administrative work alone has exponentially increased, yet our compensation structures have not adapted or even received compensation in the first place. The RBRVS functions within the confines of the law, and that law, often influenced by non physician stakeholders, defines our work. In 1989, when the Omnibus Reconciliation Act was signed, the Berlin Wall fell, symbolizing the end of an era. Yet, the walls of bureaucratic control were being erected. For general surgery, the tragic truth is zero representation at the formative stages that led to its current predicament. The ACS, as we've shown time and time again, does not represent general surgery. This lack of genuine representation has led to regressive reimbursement patterns, systemic devaluation of essential services, and ultimately, a looming crisis. The effects of these systemic decisions are not immediate. They trickle down over years, making it harder to see the direct causal links. Adjustments made today might not manifest in your paycheck for 3-4 years. In effect, this is actively deterring promising individuals from entering essential but low reimbursing and underrepresented specialties because the best and brightest will inevitably gravitate towards better compensated fields. Our reimbursement and autonomy have been and continue to be systematically stripped away, with over a 30% inflation-adjusted decrease in physician reimbursement since 2001, and a massive deliberate shift of RVUs and dollars from WRVUs to PERVUs. The implications are dire. This forces physicians to work harder for less, making dimes on the dollar, or to sell out to hospital systems, further eroding independent practice and physician agency. Understanding this system is not an academic exercise. It is instrumental in addressing the most pressing contemporary problems facing medicine: burnout, physician shortage, and the deteriorating health of our own profession. Ultimately, this is not just about money, it's about the lack of physician input and the alarming instability of our industry. Imagine any other profession where your compensation is explicitly tied to another person having to suffer. This Game of Thrones infighting, where one specialty's gain is another's loss, is fundamentally unjust, unsustainable, and flat out demoralizing. It pits us against each other, creating factionalism and preventing a unified front. This system is antithetical to the natural way we think. We are trained to give holistic, dynamic, individualized, and multidisciplinary care. We instinctively understand that good patient outcomes require complex coordination. Yet, Medicare fails to compensate fairly for these essential services. Instead, the payment often implicitly comes from physician services. When physician reimbursement decreases, the immediate impact is a reduction in support staff and the overall infrastructure that enables quality care. This directly and inevitably harms patients, all of us. For us, knowing this history, understanding this intricate, manipulated game is not about being greedy. It's about self-preservation, professional integrity, and patient advocacy. I will leave you with this sobering truth that most of us never escape these tricks because we don't know that we're being played. We take decreasing reimbursement as natural, loss of autonomy and lack of representation as inevitable, and getting a couple more RVUs, effectively robbing Peter to pay Paul, kind of like an act of mercy. We believe the government messaging and stakeholder control instead of studying our economic history. We need to learn this game and understand its rules to know how to navigate and engage these stakeholders. Because if we know the tricks, we are infinitely harder to manipulate. Only then can we start to preserve ourselves, protect our families, heal the profession, and restore the quality of care we deliver to our patients.